Hello, everyone, and welcome to PerfWeb 97, Day 2. We'll continue with this portion of the program. I'm here with my esteemed colleague, Vicki Carlyle, whom you all know from before. And she is, of course, our Director of Adult ECMO Specialist, Nurse ECMO Specialist. She's a CCRN, a BSN, and she also has is also Adult ECMO Specialist Certified, which has its own designation. I'm going to talk to you a little bit about that towards the end of my opening remarks, but let's jump right in. Okay, as you all know, you can reach out to me at contact@perfusioneducation.com and ask any questions you might have, suggest any topics you have, ask about register, whatever it is you need to do. Reach out to me. That's how you do it, okay? The next thing up is our telephone number. You can call us at 832-239-5358, 832-239-5358. Next. And here's our scroll bar, as you see down at the bottom of the screen right there. It's on during the entirety of the case. You can find our YouTube channel, our Facebook, it's not Twitter, it's X, so you have to change that. And I think also, what else do we have? LinkedIn, YouTube, Facebook, what else?
The app.
It doesn't matter. Next. Go to the next.
There's the app.
I can't get anybody to answer. So here's our app, our critical care perfusion app. Please take a look at it. It's only $2.99. It's got some really good stuff in there. I use the Perfusion Quick Calcs every day, but you can check it out on the Apple Store, or App Store, or the Google Play Store. Okay, next. And here's our podcast. So you're driving in a car, you want to listen to the program, you can do that. It's live on whatever your favorite streaming software or platform may be. And I think next is going to be, if you pull up our site, here is our site. Now, the Adult ECMO Specialist Training Course is right now designed as a full training course. I'm going to need y'all's help with this, okay? So I need you to either you can do it. Hey, Jeff, how are you? It's good to see you. That's right. I forgot about that part. Thanks, Jeff, for reminding me. I'll say that at the very end, but thanks for signing in. It is designed to prepare a person to sit for and pass the ELSO Adult ECMO Specialist Certification Exam. It's two parts. There's a didactic portion, which is about 17 hours, which would come to about 20.4 CEU for perfusion, but nurses are 1-to-1 and APPs are 1-to-1 as far as CMEs are concerned. And then it has a simulation portion, and that simulation portion is done here in Houston. So people that take the course do the didactic online, which is live. We use a hybrid system, including Zoom, but you have direct interaction with the speaker. So it's live with all of the participants in the screen at the same time, so people can talk to each other. I think you would find it very interesting. But anyway, if you will go to mediweb.us, click on the Adult ECMO Specialist Training Course, look at the curriculum, and my question is, do I want to get this approved for Category 1 CEU live through the ABCP, so that you guys can get those credits, which would be about 20.4 for, what would be a very affordable price for only the didactic. The simulation portion of it's really the more expensive portion of it, as you could well imagine. Is it something that the market really does need? So if you would look at the agenda, look at the talks, and take into consideration whether, and we have real experts that give these lectures. Dr. Matoyer, I know you know him. Of course, Michelle Lee, she's a critical care, PhD critical care pharmacist. We have intensive care medicine docs. So we have a lot of really good, excellent faculty to give these lectures, where we work with a lot doing ECMO, so we know they really know their stuff. But if you could let me know, I would appreciate it very much. And then lastly, so you can take that down. Lastly, and Jeff Campbell reminded me of this, is that the American board is requiring that we do kind of a roll call, soft roll call, if you're claiming this for Category 1 CEU, which everyone has already signed in and stuff. And then the evaluation will be up for 1 hour after the program that has to be completed. Now, that's after the full program, right, Magic? Yeah, so on Friday, at the end of Vicky's final lecture, you'll go on and do that evaluation right away so that you can get full credit for that, okay? So I appreciate everybody once again. Thank you very much. And I'm going to turn this over to Vicky. And I'm sorry. Oh, Thomas, bring Thomas up. Thomas DeSalvio. He's now, yesterday, if you all may know, I was sick. Thomas, you need to move to your right. Oh, you need to move to your right. There you go. Now you're in the middle. There you go. And probably be good to get away from the sun behind your back because nobody can really see you.
Now he's upside down.
Yeah. So I'll let you work through that. But the sun's a little bright, so it messes you up. But you don't look too terribly good. So I'm sure you can figure that out. But anyway, he's sick now. I apparently made him sick. So let's get started with the program. And I'm going to turn this over to Vicky Carlyle, and let's go ahead and get started with intra-aortic balloon pump basics.
Okay, very good. So yeah, intra-aortic balloon pump basics. Y'all know me, Vicky Carlyle, and I have no reports or relationships with any ineligible companies. Okay, so we're going to start with just reviewing coronary perfusion. So the coronary arteries arise from the sinuses of Valsalva, which, if you look at this top picture here, is right about where this line is. Is it showing up okay?
Is it working?
It is. Can you see it?
Oh, yeah. I'm
Okay.
looking at the wrong thing. I'm sorry.
So this little bulging area of the aortic root has 3 cusps on it. You have your left cusp where your left main coronary artery comes out of. Your right cusp has, of course, your right coronary artery. And the third one does not typically have any coronary artery coming out of it. It's the non-cardiogenic cusp.
Or non-coronary cusp, we call it, is what we call it.
The non-coronary cusp.
That's what we call it. You have the left,
it doesn't
the left,
usually have
right,
anything.
and the non-coronary cusp. Yeah.
The non-coronary, correct. So it occurs right here before the aortic valve on the aortic side. Okay. The coronary arteries receive approximately 5% of the total blood coming out of the heart, with most of your left main being perfused during diastole. About 75% of the perfusion going down the left main happens during diastole, with the right coronary getting approximately 50% of the perfusion during diastole and the other 50%, of course, during systole. The right side does not have as high of pressures in the chamber, in the right ventricle, so it doesn't necessarily have that effect on the perfusion like the left side, where the left ventricle gets a much higher pressure during systole, and it kind of compresses the arteries and reduces flow through the coronaries during the systolic part of the cardiac cycle. So huge amount when we're talking about perfusion through the coronaries. I'm going to be mostly referring to the left side because that right side is not as affected during the cardiac cycle. It's kind of 50-50 either way on the right side. Okay, this 5% is approximately 250 mils per minute of flow through the heart. Okay, now the thing to keep in mind with the coronaries, the muscles always being, of course, very active with the cardiac muscle, very demanding as far as oxygen extraction, and it has an extraction ratio of about 70 to 80%, even at rest. Whereas the rest of the body, we're extracting approximately 25% of our oxygen. So very high oxygen extraction in the coronaries. This means when the heart needs to increase its oxygen for increased demand, it usually has to do that by increasing flow. It doesn't have a whole lot of room where it can extract more oxygen. This 70 to 80% coming out before it goes back into the right side of the heart is why we can only truly measure a mixed venous sat from a pulmonary artery catheter. It's, of course, not a mixed sat because it's arterial or venous mixing in the heart. It's mixed because you're getting the blood returning from the upper body, the blood returning from the lower body, and it has this blood returning from the coronaries itself, which can make about a 5-point difference. If you draw your mixed gas from your vena cava and from the swan, you'll see about a 5-point difference in a normal person, of course, without any kind of heart issues and so forth. Okay. Coronary perfusion pressure, of course, is the difference between the aortic diastolic pressure and the left end diastolic pressure, or your wedge pressure can be used for that. And it's basically the amount of pressure that is pushing blood through the coronaries during the diastolic cycle. Okay. If you want to calculate that for the right side, you could use your CVP pressure, but again, typically we don't refer to the right side on the coronary perfusion. We're usually referring to the left. Okay. Do you have anything on that one, Joe?
No, ma'am.
Okay. All right, so with that in mind, we'll go to this next slide here. This slide is actually showing the flow of blood in the coronaries themselves during the cardiac cycle. So this is your systolic phase and your diastolic phase. So you can see very low amount of flow through here. It's the smaller area showing about 25% of the perfusion to the coronaries, and of course the 75 being here. This part here is your isovolumetric when your heart's contracting, but none of the valves are open yet. So the pressure goes way up, but the volume doesn't change. Then the valve opens, and you get the resulting perfusions through here, with the peak on diastole being about midway through. So looking at this is kind of the whole point of the balloon pump. If you are having problems with perfusion to your coronaries, if you had to pick a place where you could improve perfusion to the coronaries, of course you would pick the diastolic phase of the cardiac cycle. That's where you have the most potential here to send more flow to the coronaries. Okay. All right, so I do have a chunk of history with the balloon pump here. But for time's sake, I think it would run us long. So, Joe, I'm actually going to go through the history fairly quickly.
Very unusual. Very unusual.
I am a history fan. So Adrian Kantrowitz and Arthur Kantrowitz in the 50s, knowing that the perfusion during the diastolic phase is their opportunity for enhancing flow to the heart, they started working on different ways to send a systolic blood pressure into the aorta during the diastolic phase. They tried different approaches to this. One of them was wrapping part of the diaphragm around the abdominal aorta and had it hooked to a pacer wire, and they would zap it, and it would kind of like squeeze the aorta, putting some back pressure on it during the diastolic phase. But the very first one they tried, they actually had an extension from the femoral artery where they fed it back up into the aorta, so that by the time the systolic pressure wave hit the femoral artery and sent it back up, it was in the diastolic phase.
Oh, that's interesting.
And that's how they originally proved that they could do this, and is what's shown in this picture here on the left. This is actually in a canine with that femoral, bypass sent back up. And you can see it definitely gave this systolic pressure during the diastolic phase. This bottom one is showing the improvement in flow in the actual coronary arteries themselves. So there was also other things they tried, rapidly removing and returning blood, and external leg compressions and things like that. But eventually they ended up with their auxiliary ventricle, which is shown here in this picture. they actually would dissect the aortic arch. And this is a kind of a diaphragm surrounded by a air chamber. You can see the air chamber here on the bottom. So they would inflate the air chamber on the outside of this, this chamber, and it would basically act as a second ventricle.
Wow.
And that was their first inserted device. Of course, you can guess multiple issues with this, with the driveline going through the chest wall. You got infection risks. These are Dacron grafts here, but also clotting issues, right? We have no circulation going to some of these areas, pockets here and there. Backflow would have to come backwards to get to the head circulation here. Okay. So yeah, talking about the issues here, 1962 is when they started working with the balloon. They intended for the balloon pump to be a permanent inserted device for a long-term treatment. So they really were focusing on trying to get it through the chest wall, where they could go home with it, and that sort of thing. Okay, first successful use in 1967, 7 hours of balloon pump therapy on the 45-year-old heart attack patient. She did very well. Okay, this gentleman here actually went home, Haskell Shanks, but ended up passing from an infection through the driveline through his chest wall here. And the second one they sent through home with that also had an infection. Okay, so just going through it kind of quick. Fully automated systems where they incorporated automatic timing and so forth with Asti and Siki. You can see them up here showing their strips. And here's Mr. Kantrowitz. These are your first one here, your core art, 1991. Of course, then Datascope and the Aero AutoCATs. I think we're up to AutoCAT 3 now. I don't really use those. Most of the time I'm using them, CS300, which is McKay Ginnigy now, I think owns them. Okay. All right, so indications for balloon pump. Most of these are going to be no surprise, and everybody's probably real familiar with them. So acute CHF exacerbation with hypotension, not just somebody that needs diuresis and so forth. High-risk PCI to give a little bit of extra support for when they're getting reperfusion to those areas. MI with decreased left ventricular function with hypotension. MI with mechanical complications, so like mitral regurg, with papillary muscle issues and so forth, septal wall issues. Low cardiac output state after CABG, that's one of the real common ones there. Failure to wean for CABG, I would probably list that more as difficulty to wean. As if you really can't wean, you'll end up on probably Impella or ECMO at that point, but difficulty weaning. A bridge to definitive treatment. So somebody that's still having angina or ischemia, that sort of thing, waiting for intervention, or somebody long-term kind of holding for like heart transplant, that sort of thing. Cardiomyopathies, myocarditis, severe cardiac contusion, and then left ventricular venting during ECMO, as far as preventing pulmonary edema and so forth. Again, probably, yeah, go, I know already, go ahead.
Yeah, so I mean, is there any data that supports the balloon as a LV venting device? Now, I could understand if we're on VA ECMO with some cardiac output, for example, you have some pulsatility, and you want to reduce that afterload. But of course, you know, if you're cannulated either centrally or you're cannulated even peripherally, once that balloon deflates, you know, during the systolic phase, you're flowing now either right into the aorta just above the valve or retrograde back up. So I have a hard time believing that it would be very good as an LV vent, but is there any data to support this?
They do have several, and it is listed with also as far as ECMO venting strategies, and I believe it is more related to the deflation part, actually opening the valve more than just a direct unloading of the ventricle. It's giving a easier opportunity for the ventricle to kind of unload itself. So
If it can.
if it can, now that's the controversy, if where we are at on that spectrum, right? Impella being probably the device of choice.
Now, Jeff Campbell says, and it's a good question, that many of these same indications that you have here would be are better served with an Impella. I said I agree with him to a point, but can you address? I don't mean to throw you off here, but I want to make sure that we answer people's questions.
We are going to kind of touch base on that a little bit further in the presentation, but of course there is a spectrum for all of these patients on what amount of injury we're talking about. The balloon pump kind of is limited once you get to needing more than about 15 to 20% support. The balloon pump's probably not going to cover it. So how far along, how much damage
is perhaps for something that's a balloon pump would be suitable for, may be overkill, and I think there are greater complications with Impella than with balloon pumps.
Certainly.
And I apologize.
Positioning issues, right?
Yes,
positioning
exactly.
issues. Now, for instance, somebody with low cardiac output after CABG, are we talking somebody that's really in more of a cardiogenic stunning phase where balloon pump won't be enough? I can't tell you how many times we've started with balloon pump and ended on Impella for that exact reason, right? Knowing how the patient's going to fare in those phases maybe is the gray area, and they start with balloon pump, not realizing how much impairment there is. Where, of course, like you said, Impella can do up to 100% if you get a 5.5.
Sure. Okay.
But in other situations, the Impella is overkill, where you only need to perhaps improve perfusion, and the heart can kick in on its own with the better perfusion.
It's more of a supply problem.
Correct.
Yes.
Correct. So any of these patient groups here can be on either end of that spectrum. Okay. This graph here, you guys probably are familiar with it, but it's kind of that circling the drain that happens once we start having myocardial dysfunction, the systolic side and the diastolic side. So you kind of end in this spiral where you lose your cardiac output. From there, you're going to lose your systemic perfusion with hypotension. This, of course, worsens your coronary perfusion. And then you're going to get this vasoconstriction tachycardia kind of a compensation reflex there. So less perfusion to the heart, but we're trying to make it work faster to give us better supply. This is going to worsen the ischemia, worsening the dysfunction, ends in death. Same on the diastolic side. You're going to have an increase in your diastolic, your wedge pressure. That's going to give you more wall stress. Wall stress on the heart always means more oxygen demand, and of course, dysrhythms and so forth.
And decreased flow.
Decreased flow. So you're getting kind of like double whammy with the systolic failure and the diastolic failure. Pulmonary congestion, so you're going to start putting more afterload onto the right. Hypoxemia. Now you're more ischemic again, down to death. So this has to be interrupted at some place. It's just a spiraling cycle that just feeds back on itself, and the balloon pump can interrupt and resolve this in several of the steps, which we're going to kind of talk about here. Okay. Here's a chart that's kind of showing a percentage of the patient groups that do get balloon pump, with cath lab support being our top one. So 21% of our balloon pump patients are there with cath lab support. which is where I feel like the balloon pump really shines, is when there's some sort of blockage or some sort of impairment in the coronary's flow to the muscle of the heart itself. You can go a long ways by putting a little additional pressure on that coronary perfusion pressure and getting past those blockages until it can be resolved, saving a large amount of heart muscle. Cardiogenic shock being the second most used, this one having to do with the afterload reduction as well as the increased augmented pressure. And then all of your outliers here, ventricular failure, that's going to be perhaps using for pulsatility on the bypass while you're doing heart surgery. Those
Which
type
is actually,
situations.
interestingly enough, using pulsatile flow from the perfusion device itself, especially our centrifugal pump, does not have any, there's no improvement in renal function, but the only studies that have ever demonstrated any improvement in renal function during cardiopulmonary bypass where pulsatility was being used was with the balloon pump.
Yeah, very good. Refractory angina is just giving, angina is from perfusion issues. So if you can get better perfusion, you can help with that and so forth. So no real surprises here. But again, cath lab, I really feel that's where balloon pump shines the most. Okay, so contraindications for balloon pump. Septic shock is considered a condition with more of a high cardiac output, especially in the beginning where you have vasodilation, so real low SVR, real high cardiac output. So not really great with balloon pump at that phase, but up to 30% of these septic patients will eventually end up in like a septic cardiomyopathy with a decreasing and rather crashing cardiac output at that point. Then that's where the balloon pump would be appropriate. Uncontrolled bleeding, coagulopathies, because you don't want to end up with huge hematomas and peritoneal bleeds and so forth. These are usually inserted femorally. Moderate to severe aortic regurgitation. So if you have an aortic valve that's insufficient before you put the balloon pump in, and then you have the balloon pump inflating and putting back pressure on that aortic valve, it's just going to kind of like collapse back into the ventricle, and you're just going to be displacing volume back and forth and end up creating a wall stress to the ventricle. Severe aortic stenosis. This is again, you have a stiff valve that's not opening all the way, and you're putting some back pressure on it. You're putting them at an increased risk for that valve to tear. Aortic aneurysm and aortic dissection. What's wrong?
You think that with aortic stenosis that inflating the balloon would disrupt the valve?
That is one of the
That is-
contraindications.
really?
I mean, you're putting that amount of backflow pressure on a valve that is stenotic going this way, right? And then augmented pressure on your balloon it could go very high, but on average, let's just say 120 back pressure on it when it's not even used to feeling that back pressure. You can tear a leaflet.
Interesting. Okay. I didn't really consider that.
Yeah,
Right.
it's one of the, and of course, physician discretion on any of these contraindications. Aortic aneurysm or aortic dissection, of course, is probably the most absolute contraindication, because that's right where your balloon is going to be sitting, and you're just like repeatedly pounding on this weakened part of your aorta. This one actually already has a transmural thrombus back here. So definitely no balloon pump there. Severe peripheral artery disease, more for the insertion femorally, unless, of course, it's previously been treated with stenting and so forth. Irreversible brain damage, because there's no end game here, just kind of prolonging something that's not salvageable. End-stage disease with no possible end game, not a candidate for LVADs or...
It's never stopped anybody.
I mean, it still happens, right?
Yeah.
So and of course, it's I've seen patients on different degrees of these still get put on balloon pump at the physician's discretion, with the exception of an aortic aneurysm or dissection. I've never seen that one end up on the balloon pump. Okay. All right, so insertion of the balloon pump, typically, again, since most of our cases are coming from cath lab, most of your balloon pumps are inserted in cath lab. You'll get some inserted in the OR post-CABG. Occasionally, prior to CABG, again, for that pulsatile flow while on pump. I have had a handful inserted at the bedside, typically from a patient that perhaps came out from bypass surgery, some cardiac stenting, and kind of decompensated through the night, so the physician can put it in at the bedside. In my experience, I would say probably 85% in cath lab, maybe, I don't know, 10% from the OR, and maybe 5% at the bedside. There's no published numbers on this. It's just from personal experience on that one. This Baldetti study here did actually study bedside insertions versus cath lab insertions, and there was no difference in outcomes, actually improved placement a smidge if they were put at the bedside versus cath lab. Small increase in vascular issues at the bedside, but came out more or less the same, 98% accurate, a couple repositioning with chest x-ray, which again is one of the benefits with the balloon pump, is you can get placement verification with chest x-ray versus Impella, you have to have the echo at the bedside.
Yeah.
Okay.
So Vicki, I have a question. How often have you seen doctors use at the bedside, use the guide wire as a guide before inserting the balloon to measure how far they want to put the balloon in?
Use the guide wire for what?
Say that again. We didn't hear you.
So you take the guide wire and you put it on top of the patient. You don't put it inside the patient yet, but you use it as a guide to estimate how far to push in the balloon pump?
No, not typically. I've not seen them do that.
I've seen them do it with the balloon.
With the balloon
itself, to see how far, where it needs to be on the leg for the length. But, I don't know. I think placement, I mean, we can make it real complicated, but you get a pretty good idea doing it that way. Put it in, take a chest x-ray, leave the plate under it, see if you need any additional positioning, make the position, take another x-ray to confirm it, and you're done. I mean, let's not overcomplicate something that's not too terribly complicated, right? I don't think it's not like an Impella. That's a little more challenging.
Yes. And I think visually, it's pretty easy to kind of visually estimate your depth, especially with more experienced physicians. I don't see them really measure at all. They can kind of just get the thing in and shoot an x-ray. Sometimes no repositioning even needed. They've gotten pretty good with it.
Mm-hmm.
And you have a little bit more room with the balloon pump, where Impella is down to just like a centimeter off, can really blow the game. But balloon pump, you got a little bit more leeway there.
Agreed.
Okay. This is an insertion kit here. Of course, it comes with the 2 trays. This one up here is going to be like your access needle. You've got 2 different dilators here. And this end one here is your actual sheath. This is the guide wire around here. So, typically you're going to hand these into sterile fields for the physician. This is extra helium tubing and some pressure tubing on this side with some stopcock here. This is more the business tray here. You have the balloon is actually inside this blue cover, very, very, very tightly wrapped. When you open this part, you have the helium tubing right here, and you have this syringe with this little one-way valve. First thing you want to do is connect the helium to that syringe and put some back suction on it, like at least 30 cc's worth, and get a large amount of negative suction on that balloon, give it the smallest profile for going through the sheath. The fiber optic cable here is this orange line. Most of them have fiber optics now, but there are still They are still using them where you would have to use the arterial line in order to get your pressure waveform.
Classic transducer.
Yes, classic transducer. And matter of fact, most of the kits, you can see this here and this here are actually pressure tubing. So you have the option to do it even with the fiber optic ones, just through this little side port where your guide wire and everything is going to go through. When you take that out, it can be transduced. It's just a regular arterial line with pressure bag and so forth. Removing this blue cover from the balloon is just very slowly, nice and straight, no bending. You're not gonna put flush on this balloon before it goes in through the sheath. Sometimes, because the way the balloon is wrapped around, you'll get some blood kind of that channels through those folds, and that's still perfectly normal. Usually no issues there. Now, once the balloon is in and it's been turned on and it's inflated, now you don't want to pull it back out. When it comes time to remove the balloon, you don't want to pull it back out through the sheath because it's inflated. It no longer fits through. You can, of course, force it and put a lot of pressure and pull it through there, but you're risking tearing the balloon, some of the pieces getting dislodged into the patient's circulation. The balloon pump itself is meant, when it's time to remove it, to come out with the sheath. The only situations where I see that was different, a patient that was very, very long-term, probably a month and a half, with various different balloon pumps, and the physician knew this ahead of time and put a very large sheath in there, so it took away the risk of tearing the balloon and so forth. But I've only seen that once.
Yeah, that'd be bad.
He had I don't know, he kept popping balloons. He had like a large amount of plaque in there. And so they had to switch him out at least 3 times that I can think of, but he had a very large sheath, so it was able to do that. All right, placement. So you can, most of them are going to be put through the femoral artery using the Seldinger technique. You can also have an off-label axillary approach that you really don't see very often, but it is there going through the subclavian or even the brachial artery. The balloon pumps, depending on which model, even some of the same company have different models with these radiopaque markers. So depending on which one you have some of them with a marker up at the most proximal and a marker at the most distal. So you can see the abdominal location as well as the aortic placement up more proximal to the heart. Most of them that I am familiar with nowadays just have one radiopaque marker that's up at the most distal tip. Some of them even have a 2-tone tip where it kind of gives the user a directional, so they know if it's facing from the femoral approach or the axillary approach. I don't really see those very often, but they are there. Correct placement of the balloon pump, 1 centimeter below the aortic knob, at or above the level of the carina, which, interesting enough, there's been several studies with this carina showing as a very good landmark, almost the preferred landmark now for placing the balloon pump instead of the intercostals and the aortic knob. But all of them are still correct landmarks. Okay, so you can see here, this is CT image on this side. Giving your line is the same on both images. So this is going to be kind of your aortic area here that we're looking at. This being the carina right here, and there's the mark there. This right here is your AP window, so where your pulmonary artery kind of crosses in front of the aorta. That's also a very good landmark that I like to use, having the tip right in that area. So 1 centimeter below the aortic knob is where your line is here. So anywhere in this area here, you have a little area, more, I guess, room to have it a little higher or a little lower than would you have with
Yeah,
the
you got a
impella.
little bit of real estate. It doesn't have to be precise.
Of course, too high, and you're occluding the left subclavian artery here, which branches off to your carotid and your left radial. So one of your assessments can be
No, your
checking that.
vertebral.
I'm sorry?
Subclavian goes to vertebral, not carotid. The left carotid is further back.
Okay.
The left subclavian branches to the left subclavian. I mean the left axillary, and the vertebral comes off.
I see. Okay.
The carotid's separate. The right carotid comes off the innominate.
Okay. But definitely you can palpate a difference on your left radial.
Yes,
if
clearly.
it's occluding. Knowing that flow has been disrupted kind of lets you know that you're in too deep. Same on the lower end here where you have your renal arteries. They're kind of off of this view, but down here where if your balloon pump's too low, you could be occluding flow or disrupting flow to your kidneys. So decreased urine output is a sign of balloon pump placement issues.
Yeah, and way decreased efficacy, right?
Sure.
It's not going to work.
Sure. We're going to talk about that a little bit here too. Do you have anything else you want to add on the X-ray images here?
No, I think that's
have you seen them using
really
the
good.
carina?
Have I? I'm sorry.
Have you seen the articles with the carina being the new landmark?
No, I have
It's
not.
pretty good.
No, I think that's really interesting. I think that works. You know, I agree with you what you said, which is, you know, you have a pretty good, you know, area to work with. You know, you don't want it up to where you see it curving. Because then you know you're in the transverse arch, or at least the start of
Yeah.
it. So, you know, you want to make sure that it's not up that high, and you don't want it too low because, you know, for obvious reasons. The other thing too is, and this is sort of getting off topic a little bit. I hope
That's
you
all
don't
right.
mind.
Go ahead.
But I have gone into, and I don't know how many of my colleagues may have seen this, where I'll look at a balloon pump that has a classic transducer, not the fiber optic, and I will see the tip of the balloon catheter right there, just distal to that left subclavian artery, and they have the pressure bag, little pressure bag for flushing the transducer, and it's got a whole big chunk of air at the top of it, which is fine until you go to transport or move the patient, and you take it and you lay it down, and then you get some air in the line and flush it under 200 millimeters of mercury pressure. It's very easy to understand
300.
when you, can you throw that back up, that image back up? I'm sorry. It's very easy to see how something in that position where you have the arrow on the right image right there by that subclavian, how 200 millimeters of mercury pressure could blow that all the way back and go up the innominate and the left carotid very easily.
Sure.
Even maybe
some
even
of
go
the
down the
coronaries.
coronaries, right? So I get very frustrated because I see that still today. I don't know if you have seen it.
I have.
But it's very, very frustrating. And it's so incredibly dangerous. And you have a pressure bag like that, you have to spike it. You have to get all the air out of it, make sure no air can get into that system because it is quite dangerous.
Yeah. And I think a lack of understanding sometimes on where that port exits, and you know, it's just a pressure bag. It's something very familiar to everybody, and it's not necessarily catching the importance with them.
Understood.
But
I've
yes,
seen that in the
I've
operating
seen
room
it.
many, many, many
I've seen
times
it.
with some of my own colleagues, and they're not teaching perfusionists in school balloon pumps. I see many students coming out of perfusion school now that have no idea how it even works.
Yeah.
It's not part of the training.
Agreed. I don't think there should be air in anything on a pressure bag.
Agreed.
Bad news. Okay, very good. All right, so here's a depiction. Without this up here being highlighted, you send this image down to the radiologist, and it would be so easy for him to not know if it's coming femoral or axillary, so forth. So the radio markers, this is one of the two-tone ones here, where you can see like the darker segment and then the lighter segment. That means the balloon pump is going this way. But again, that's not as obvious on chest x-rays as it is in this image. And sometimes you have sternal wires, pacer wires, chest tubes, drains, all kinds of things in the chest x-ray image, and they may not even notice the little radio pig marker. So if you're sending an x-ray to verify balloon pump placement, just make a note in it, give your radiologist a little help. sometimes it can get missed. Okay, and this one you can see better where your renal arteries are down here and kind of see the correct placement. You have a little bit of room, but too low, you're occluding here, too high, you're occluding there.
Of course, your mesenteric artery is probably a little higher than
Yeah,
that.
yeah, the mesenteric, I think it is actually.
Yes, it should be. Most people.
Most people. Okay. Because we're starting to get a little tight on time, this is your Wigger's diagram. I'm sure everybody has seen this. It's just depicting the flow with the pressures through the cardiac cycle. So your mitral valve is here. When the ventricle contracts at the start of systole, it's going to go until the pressure exceeds that in the aorta. Then the aortic valve opens. Blood flow's coming out, all your volume's coming out. Once the aortic pressure is now higher than the ventricular pressure, now your valve is going to close and so forth. Again, this is the diastolic phase. So with that, if I could superimpose this image right on top of it, that's what this is kind of reinforcing, that diastolic phase, which I think we talked about, so I'm just going to skip through the rest of that and move on to here. So counterpulsation, I like to think of the balloon pump as more two machines rather than just one, because it really has two jobs that it does, your inflation and your deflation. So counterpulsation just means pulsing opposite of the heart. So diastolic pressure would go up, systolic pressure would go down. So it's opposite of what the heart would normally be doing. And that's, of course, the goal with our balloon pump. So here on this side is going to be our inflation part of the machine. You can see the balloon here has inflated. Let's say it's a 50 cc balloon. Once it inflates, you've got 50 cc's of volume being displaced. It's being displaced this way and this way and into your coronaries with a driving pressure behind it that it wouldn't normally have in diastole. So it is increasing perfusion to these areas. Of course, you'll have some that goes this way as well, but we're really targeting all of this up here. Okay? And that happens with the closing of the aortic valve. And again, just more pressure behind improving perfusion. It's what we would call augmenting the diastolic phase. We're augmenting it with this flow, the increased flow, the displaced volume. Okay. This part over here is our systolic part of the machine. Same thing. If we have a 50 cc balloon that was just inflated, displacing that 50 cc's of blood volume, when that balloon deflates very abrupt like that, now you're creating a negative suction kind of force of that same 50 cc's. So what you get is a sudden drop of pressure in the aorta, which is afterload reduction. Okay, so that is our basically improving less work for the heart, basically. It's working less hard, using less oxygen, and our inflation is sending more oxygen to it.
It's like pushing a door open with somebody pulling it from the other side.
It is very much like that. So, of course, we'll just go through here. Diastolic augmentation, that's your inflation. We just talked about that. So if you're increasing your diastolic pressure and you are decreasing your systolic pressure, your augmentation waveform is enough that you still end up with a net overall improvement in MAP. Okay. Decreases wall stress up to 20% because we've got that suction on deflation. So our heart's not having to be as resource demanding. I think that's about it. Yeah. Do you have anything you wanted to add with that one?
No, ma'am.
Pretty
Looks
covered.
good.
And again, about 10 to 15% assist with this. The balloon pump cannot augment a cardiac output that's not there, right? So there's, when you end up on the more supportive machines, your Impellas or your ECMOs. Okay. Again, here's the cycle, this being your balloon, inflation with the cardiac cycle timing. Okay. So aortic valve, That's going to be our inflation timing, lines up right at the end of your T wave. And then you want your balloon to deflate before the next cardiac cycle. So electric followed by mechanical, so right around there. Okay. All right, so this ratio is kind of a quantitative number to actually show that work being done. So DPTI is your diastolic pressure time index. This is going to be pretty much your measure of how much blood supply we're sending down the coronaries. And it is, of course, during diastole, so you're going to calculate this using your coronary perfusion pressure and your diastolic time. So how long were you in the diastolic phase in order for that blood flow to get where it needs to go? Coronary perfusion pressure, again, is just your diastolic blood pressure minus your wedge or your LV EDP. Okay, so this is telling us how well we're sending blood to the heart. Our tension time index, this is the demand part. How much oxygen is your heart needing? And it's going to be your systolic pressure by your systolic time. So how long is the heart having to use this increased demand of oxygen? Okay, so these two numbers are put over each other in a ratio called your endocardial viability ratio, and it's just depicted as a number. So 1 or more is good. Less than 0.7 is typically the start of ischemia, where you're not sending as much to match demand. So 0.7. Okay, and then I have like a little equation if I can get it. Okay, there we go. So this is kind of just to work it out so you can see how that number works. So we have a patient here that's hypertensive and tachycardic. So to calculate these out, you're going to see your DPTI. So, of course, the perfusion pressure is going to be your diastolic minus your wedge, so you get 80. For the time spent, you're going to basically 2/3 of the cardiac cycle, with this 0.2 seconds being the systolic phase is almost standardly left at 200 milliseconds. And it comes out as 24 millimeters there. Okay, and then the tension time index, this is going to be our systolic pressure, okay, minus our, by the time that we spent there. Again, pretty standard, just leave it as 200 milliseconds for the systolic part of the cardiac cycle. Doesn't really change as much as the diastolic part. And that leaves us with a ratio of 0.67. So this patient is having some ischemia.
Can I ask a question? I'm
Yes.
so sorry. Can that be simply demand ischemia? In other words, not necessarily because of atherosclerotic heart disease, but just
Correct.
because of the hypertension, tachycardia, and increased wedge,
Correct.
which could be fluid overload.
Correct.
Which you're not supposed to use that term.
Yes, this one is not
Hypervolemia.
necessarily even a balloon pump patient. It's more just to show how these numbers leave room for improvement, right? So our issue here is our tension time index. So our oxygen demand, our systolic pressure is very high. So that's already putting increased workload on the heart. And then our heart rate, we are not spending as much time in diastole as we need to supply that increased demand. Okay, so balloon pump would help this by reducing this systolic blood pressure and increasing your perfusion pressure in the diastolic phase. And then, of course, get the heart rate down, increasing the perfusion to the heart during that phase would probably help with the heart rate by itself. Okay. All right, so here's the correct balloon pump waveform. This being our balloon right here during our diastolic phase. You would want, this is your assisted beat right here because your balloon does the assistance, your unassisted beat here, and then the balloon. So landmarks that you're looking for on this for your inflation machine part of this balloon pump is going to be your dichrotic notch. You want that to be at the same level that your balloon inflates here. So you don't want to see the dichrotic notch because that means it would have gone off too late, but you want it to inflate where the dichrotic notch would have been. And then for your deflation, you want to go from your end diastolic point right before systole here to your end diastolic point right before systole here. And you want to see that reduction on the deflation side for your afterload reduction. Okay. So this is going to be your DPTI here. And then this down here is going to improve your tension time index. So that ratio is helped on both ends.
Just so you know, you may want to go, okay, you can stay right there. I got a very good message here from Francis Delgado, and he says that more of their role, he's a perfusionist, getting the timing right while looking at the machine. That has been their most difficult part. How well the IABP works is based on, of course, getting the timing right. Agreed with that. But he's having some concerns about timing and making sure they get that timing. So if you can, spend a little extra time on that.
Okay.
If you don't mind.
Yeah, so timing is really everything with the balloon pump because we're talking about different parts of the cardiac cycle. So, of course, if we're putting a balloon inflation on the part of the systolic cycle, then we're increasing afterload and potentially causing more damage than the balloon even being put in the first place, right?
I think his specific question, though, is more going back to where you were, maybe getting rid of all those lines and going over the waveforms again, and when you're inflating and when you're deflating, to make sure that he sees what the waveform, and that this is on obviously a 1 to 2 or something else,
yes.
But that you can go over those waveforms exactly.
So as far as timing, you can use it in reference with your EKG tracing, but I feel like you're better served using your fiber optic or your pressure waveform because that's what's actually affecting
happening.
In the actual aorta. So it has to be on 1 to 2 because you have to be able to compare it to your unassisted beat, to your assisted beat to get the timing and so forth. And we're going to go through all the waveforms that show the different timing errors. But all right, so here's systole. Right here, compared to the other one, is where your dichrotic notch would be. So you would want to adjust your inflation part of the balloon pump to where this V part is as close to where this dichrotic notch would be. Okay. And you're going to see what it looks like when it's wrong here shortly in order to know when it's right. Okay. For your deflation part, the biggest indicator is going to be if you do not have that decrease in pressure. There's no situation where your end diastolic volume and pressure should be the same before the balloon as it is after the balloon, because where did that 40 cc's of displaced volume go?
Right. If you deflate too early, then it equilibrates and you aren't reducing afterload.
Correct.
It's timing. Yeah.
Or if you deflate too late, then your balloon is still in the way and you lose this.
Yeah.
It looks like it's even, but really we're increasing that afterload again.
Right.
You can look at it from your EKG cycle here for the dichrotic notch being right at the end of the T wave versus your Q for systole, but I feel like it's better served looking at the actual pressure waveform itself. I'm not sure if that's answering it or not. It might be better as we go through the timing errors to kind of see what I'm talking about. Is that what he was?
No, you're doing good. No,
Okay.
I think you're handling this well.
All right, so we'll go through, as with anything else, practice and looking at these waveforms and working them through is really how you get good at it, right? So again, we're going to start by finding our balloon. Okay, finding our balloon. This is our unassisted beat over here to our assisted beat, and We'll check our inflation part first. So here's our dicrotic notch. So we want the balloon to inflate at the same point, following it across. I can tell that this is where my dicrotic notch would be, but I don't see it. So that means I'm inflating properly. I'm inflating right at the dicrotic notch. Okay, so our inflation is timed correctly. We have a good augmented waveform here, so we can tell our balloon has a good amount, the right volume in it. It's positioned properly, and so forth. So inflation part is good. For the deflation part, which I feel sometimes is the one that gets missed the most, everybody's looking at this balloon, but the workload reduction of the balloon pump is done down here. Okay, so here is the end of diastole going right into systole here on our unassisted beat. So let's just say this is, 55. Let's say this pressure right here is 55. So we go through, our balloon inflates, and it suddenly deflates at the correct timing. And now it's down here. So you can see this decrease right here. We'll say that's, what do you think, like 46 or so?
Make it whatever. Yeah.
So that means the heart had to exert enough to overcome 55 of pressure here to eject the blood, but only had to work enough to eject over 46 of pressure here. So that's an afterload reduction. And that's what we're looking for. There's no situation where this should be level with before the balloon, because then we did nothing and potentially did harm. And that's you'll see that on some of the waveforms coming up here shortly. Okay, so, and like Joe said, it's like somebody pulling a door open on you when you're pushing on it from the other side. So I always call that my door to door. How's my door to door? So door to door. And then dicrotic notch to dicrotic notch. Now this up here, you're going to be lower there because you're lower down here, right? Your systolic pressure will be lower.
Your assisted
systolic pressure will be lower. And you can see that at the bedside. If you're in there with a balloon pump and you put the pump on standby, you're watching to see if your blood pressure goes up. When you turn the balloon pump back on, blood pressure should go down. There are patients that are super dependent on the blood pressure, where your arterial waveform is being calculated with a lot of that augmented pressure going into account. And of course, those patients you don't want to leave on standby for very long anyway, because their pressures drop. They're all diastolic pressure. Okay, so this is the correct waveform. This one here shows how you cannot assess. We have our balloon here and an assisted beat. Our balloon and an assisted beat. Balloon, assisted beat. There's no unassisted beat here to compare it to. So how do I even know where my dicrotic notch should be? How do I know what my end diastolic volume is before the balloon? You cannot assess your timing with a one-to-one. So there's no reason to print the one-to-one strips out. You don't need them on the chart. They're not necessary. Okay. All right, so here's one of the errors here. Do you want to do some of these?
I would
test
say
you like you did with the
test
ABGs?
me. Yes, you can test me. I would say, I'm going to say that is inflated grossly too early.
All right.
But I would say that deflation is okay. I would accept that as a deflation, but the inflation is way too early.
Okay, and this brings up another good point. You can have timing errors on both inflation and deflation, or you can have timing errors on just inflation or deflation. A lot of times you're going to have both, but this is an inflation error. So we'll start out, find our balloon, and then to check our inflation, remember, we always check to make sure our augmentation is good. We got a good high number there. And then where is our dicrotic notch? So follow the dicrotic notch over, and it's right around here is where it's at in the cardiac cycle. But all of this space here, this is time, right? Time during the cardiac cycle where that balloon inflated way before the dicrotic notch.
So you're prematurely closing the aortic valve.
Correct.
The LV may not have completely ejected.
It probably, with this one, it probably did not. Mm-hmm. So basically, the aortic valve closes depending on pressure in the aorta. And we just caused the aortic pressure to exceed the ventricular pressure prematurely, closing the valve. The ventricle's not able to empty all the way. Now you're having increasing wedge pressures. You're having increased wall stress, increased oxygen demand. These are the things we were trying to fix, and we made it worse. Okay? So early inflation. Okay? So here we go.
Okay. Okay, so that one I view as late inflation 1, because you can clearly see the dichrotic notch and all of it. So late inflation, and I would say that I would say the deflation is, you're getting afterload reduction. I would say that's acceptable.
Okay, yeah, so correct. We got our balloon here.
Am I getting a prize after this?
Maybe. Maybe. Should we give him a prize?
Here, that's my prize.
It's his
right here.
birthday.
It's not his birthday all week. Come on.
His birthday month.
It's been his birthday month? All right.
Yes.
So here we go. And you'll notice on this one, this augmentation balloon is kind of stunted. It's not as high as the previous ones were. I'm going to tell you why here in a second. And again, like Joe said, there's my dichrotic notch. And oh, there's my dichrotic notch. I can see it right there.
Okay, so I didn't pick that up. So I'm going to say you're right. That's a very good point. Augmentation is not that good. The balloon is too low.
No.
No. Oh, darn it. Okay, go ahead.
So, where's the gong button? No. So what's going on here? You're going into your diastolic, your aortic valve closes. That blood volume doesn't just hang out in the aorta. It runs off into circulation. There's not as much volume there for it to push back.
That makes sense.
So
Okay, that makes sense.
you don't have as good an augmentation.
Got it.
Okay, that's called aortic runoff. This is one of the least damaging timing errors. You lose some of your augmentation, but you're not actually making the heart work harder.
You're not hurting them, right?
Yes.
Good way to say it.
Okay. All right. Now we get into the real bad ones here. What do you think?
Who do you want to answer?
With Joe.
You can. Oh, you want me to answer?
You want to do it, Thomas?
Well, I can tell you both of them. It's like you have early inflation and you have early deflation.
Yeah.
I don't think you have, I mean, I don't think you have early inflation at all. I think you have early deflation.
Yes.
It could be, yes, you're not getting as, you're deflated too early, therefore, that where you see that rise coming up, I don't know if you could draw out the line, you know what I'm talking about.
There's our balloon,
Yeah.
dichrotic notch. It
See-
would be right here, but you don't see it.
Yeah, but that's okay. I mean,
It's
I think
appropriate.
that's okay. But where it comes down, you see where it's coming back up again right here?
So this
That's
U shape.
That's what I'm talking about right there.
So yes, our inflation, we have a good augmentation here. Our dichrotic notch is not visible, but it is lined up properly. So our inflation machine is good. Here's where our problem is though. Our 40 or 50 cc's of displaced volume right here, right? We got that assist, but our cardiac cycle, the next systolic didn't start till here. So we're basically ejecting in the systolic cycle against the same pressure that we started out with. We got that assist, but we got it too early.
And we
it's
can
of no
see-
value to us anymore.
Right, and we can see there's almost no decrease in the
No
assisted
decrease.
systolic pressure.
Correct.
A little teeny bit, but not much. I mean, a teeny, itty bit.
Correct. So this one, it may seem like it is not necessarily as dangerous as the other one, but it definitely can be, because what you're doing, again, that 50 cc's of volume, when you deflate, is causing a sudden drop in pressure in the aorta, and you risk pulling circulation back out of the coronaries or back out of the carotids.
Yeah, get a coronary steal.
Yes. And so you can end up getting altered mental status or chest pain even, depending on what degree. So yes, this one can still be very damaging. And of course, you're not getting any afterload reduction because you just wasted your assist. That negative doesn't just hang out there, it's gone by the time the systolic cycle started. Okay. All right.
Okay. So that's maybe a little bit early inflation and definitely late deflation.
Correct. So here's our balloon. Check our inflation. We're going to go notch to dichrotic notch to where the notch should be. I'd call that pretty appropriate. But then when we get to our deflation, here's our end diastolic, and here's our end diastolic. So
and in
it's
this
actually
waveform,
higher.
in this waveform, that deflection is actually where the balloon is deflating. The other is just pressure dissipation, right?
Yes.
Can you draw that? Show them on that screen, right there. That's where that deflection point is actually where it's actively deflating.
Yes.
So you can really appreciate the difference between the different waveforms that you were showing.
So we'll say this is like 55, but now our balloon has gone off and our assisted beat over here is more like 62. There's only one thing that would cause that pressure to be higher after the balloon than before the balloon, and that's
obstruction.
An obstruction. Your balloon is still in the way. We're making the heart work harder every time our balloon inflates. So this one, you can start actually getting ST elevation, signs and symptoms of an MI, basically. You know, you're kind of making the heart work harder. Okay. On these, typically, especially if they're symptomatic, now it's all pressures that we're talking about here. So you can end up with a patient on balloon pump that becomes hypertensive, and you're going to still have the same issues. It's all pressures. We just don't want it to be from our balloon. Okay, and if they're symptomatic, we would slow down the timing as much as we could, or retime it. It depends. Some facilities allow you to do manual timing. Some prefer auto. Okay. All right. You want this one, Thomas?
Sure. Oh yeah, so it's got early deflation, and you tricked me on that other one, so I'm going to say
I didn't trick you. It's a waveform.
late inflation.
Late inflation, yep, because you can see the dichrotic notch.
Yeah, and early deflation.
And early deflation, correct. This one has 2 timing errors. Okay, so we're not getting very much augmentation here, and we're not getting any afterload reduction here, and possibly stealing some circulation. This one I feel is like the worst of the worst.
Ouch.
And it looks like it's flipping you off because it's really what's happening here.
Yeah.
Here's our balloon.
Let's ask the audience.
Okay.
Anybody want to say what's wrong? You know, it goes to the points like we had from yesterday. It'll get added onto it. We should have had them do it. Everybody, I need an answer. What's wrong with this timing? You get 15 seconds. And 15. Okay, we'll see what the answers are. Okay, go ahead.
Okay, so here's our balloon. Here's
Jeffrey got it.
Dichrotic notch here, and it should be here. So we are inflating way too early in the cardiac cycle,
Francis?
which means we're pushing that aortic valve closed too early, and we're stacking volume in our ventricle. But when we go to look our deflation machine, we are elevated. So we are late deflation, early inflation. Both of those are causing increased workload on the heart. It's a double whammy. This guy should have gone to a different hospital.
So Jeffrey and Francis and Kay Garcia Jeffrey gets full credit, 2 timing errors, and Francis and Kay Garcia get half credit because they're both correct. Late deflation, early inflation. Okay.
So, some of you guys may remember him saying fiddle to the middle when you're doing timing, and that is so that you can avoid creating these more dangerous timing errors while you're actually timing your balloon pump. So we used to say fiddle to the middle when you're doing your timing and adjust outwards for your for the less damaging timing errors.
Yeah. Well, I like to, I don't, again, I'm not one that likes the automatic or the auto timing method, but what I normally do when they're putting a balloon pump in, we're trying to wean from bypass, let's say we're just doing it because they're kind of wimpy or whatever the case may be, I'll put my inflation very late, my deflation very early, and start filling the heart up, with the pump translocating the volume, get what looks like a good waveform that I can work with, and then I'll move my inflation back to where I can still see the dichrotic notch because I'm not off yet or completely full. I still want to be able to see it. And then I'll move my and of course, always in 1 to 2. I put it in 1 to 2, and sometimes I even put it in 1 to 3. And then move my deflation out until I see that nice, crisp, waveform we want to see. And I can see it's below. I've got good end diastolic pressure drop, and the assisted beat is lower than the unassisted systolic. And then I'll put it on 1 to 1, get off bypass. As soon as I'm off bypass and we're full, go back to it, put it back in 1 to 2, take a quick look at it. If I need to make any adjustments, make it then, and then come off. Because a lot of times using the auto timing methodology when you're weaning from bypass is really hard because the machine, it can't reason. And it doesn't understand we're not full. It sees this waveform, and then it calculates what it's going to calculate, and it changes very rapidly, especially in the operating room. It's a very dynamic environment.
And that brings up a couple good points, actually. When I say fiddle to the middle, like he was saying, on the console itself are the little markers when you're adjusting your timing, and you would want to fiddle with both of your markers more centrally, which is what the fiddle in the middle, and that's what he was just saying. So. And then you would move them out until you get the correct timing.
Yes.
Second point is bypass surgery. There's different modes that you can put your balloon pump on with auto and so forth, but there is actually a mode for no heartbeat.
An internal rate of 80.
Correct. And that way your balloon pump just operates more like a pacer, since you don't have any cardiac cycles to time it off of.
But
and it's
with the
laminar
caveat,
flow.
Yes, the caveat to that is you have to disconnect the EKG, or it keeps telling you your EKG is connected. So you have to disconnect the EKG, turn it on internal rate of 80, and then do your bypass run with the pulsatility coming from that.
Correct.
You should show a waveform of someone in PEA. No, I don't know if we have that.
We're starting to get kind of limited on time, but I do have actually the full console demonstration in another course where I do timing on the console itself, and it's a good demonstration.
Well, can we do a part 2 of this? Being part 1, and then we'll do a part 2.
We could.
Or you could do it now. It's up to you.
No, it's like a whole nother hour and a half.
Okay.
I mean, at least I think it's maybe even longer than that.
Okay.
And we're already kind of running over. So let's anticoagulation on balloon pump. Most commonly is heparin, of course. PTT ranges by doctor facility. Typically 50 to 70 is fine. If you're on 1 to 2, you are more necessary to have anticoagulation than if you're 1 to 1 because you're not inflating the balloon as often. Of course, your argatroban or bivalve if you're HIT positive. I think that's all we need to say on that one. Different studies that are showing that no anticoagulation on 1 to 1 wasn't necessarily associated with more thrombotic events.
That leg looks bad.
It looks terrible.
I think it needs to just come off.
Okay, adverse effects of the balloon pump, injury to the artery, infection. This is a picture of a ruptured balloon with a big thrombus stuck inside. So one of the guidelines and rules with balloon pump is if you start getting blood through that helium tubing, you're on a time frame now. You got typically 30 minutes to get that out. Otherwise, it has to go to the CV surgeon because of this reason right here. You try to withdraw that, it'll put a big old hole in your femoral artery.
Yeah.
So it's holding air, holding blood in there. Limb ischemia you've seen, stroke, thromboembolism. The balloon can throw clots, which is why we're checking pedal pulses and so forth. It'll just travel down to the most distal arterial bed. Aortic dissection, nothing too crazy, surprising here. Okay, so nursing management, we're doing family education, neuro assessments, those pedal pulses, limb ischemia, your color, sensation, pallor, all of that. Urine output and left radial artery assessments is for your balloon placement hourly checks. You're checking the groin hourly. Head of the bed no more than 30 degrees because you don't want to fold that groin too much. Labs, insertion site checks, so forth. Okay. All right, so management, you're documenting your balloon pump numbers, printing your strips out on 1 to 2. Daily chest x-ray to verify your placement. I've seen these suckers move, so daily chest x-rays. You don't want to turn your augmentation alarm off. I see this a lot, and it makes me crazy because if your balloon ruptures, that's how you'll know right away. That augmentation alarm should be set about 10 below your augmentation. So that's this number here.
Yeah.
What was that?
One of the things that I find about the augmentation alarm is a lot of times people get busy doing other things, so they're distracted doing paperwork, charting, and that alarm goes off, and that's the first alert that somebody's had that the pressure's dropping.
Correct. The blood pressure drop. But if that augmentation drops suddenly like that, it means your balloon just lost pressure. It's telling you that you have an issue with your balloon. It can definitely go off if your patient's blood pressures are dropping too fast as well.
Not always the balloon. A lot of times I've seen this actual patient itself that things have changed. They need increased drugs somewhere, maybe vasoconstrictors or something. The heart suddenly had a hit that just people weren't aware of, and the alarm is the only thing that saved them from catching it.
Yes, and Jeffrey Campbell was pointing out that a lot of times they walk in, they see the patient's in PEA, but the balloon pump is still operating, and it's triggering off of ECG, and they're like, well, no, the patient has a blood pressure, but all it is the balloon pump going up and down.
Yeah, correct.
So probably we need to find a strip of somebody in PEA with the balloon pump still working to
I mean, it
show
looks
that.
just like an art line almost. It's
Yeah.
just the balloon inflating, deflating. You don't have the unassisted or assisted beats showing up because there's no actual
Right, but if it's in one-to-one,
mechanical action
somebody may
to
not
those
see
EKG.
that.
Yeah,
You know,
yeah,
they think the patient has a blood pressure,
yeah, for sure.
especially when you don't understand what you're looking at. All you're looking, you just look at it, there's a blood pressure. You look up on the monitor. You're not thinking, well, where's the tube pulses?
That also brings another good point. If you're using flow track, the balloon will mess up your flow track numbers.
Very good point.
You, in order to get your flow track numbers, pause your balloon pump until it's taken that out of the equation. Okay, for cardiac arrest, you want to go to pressure mode and decrease your augmentation about 50%. You do not turn off the balloon pump. Okay.
Did we saw a balloon rupture not long ago, didn't we?
Yeah.
Because Jeffrey said he hasn't seen one never seen a fully blown one in 29 years, but I know we had one
we've seen them
recently.
We had one that they had actually made it all the way up to the little back of the console. We had to send the balloon pump in for maintenance on that one. But now, I mean, it shouldn't get that far, right? The balloon pump tubing should be on top of the blanket. It shouldn't be all buried under there. It should be where you see it every time you walk in the room.
Kind of like the ECMO tubing.
Yes,
cannulation
like you don't
site.
want to hide it so that the first thing you notice is blood going into the back of the balloon pump. You want to see it right at the insertion site, because if the balloon's way up here and your insertion site's way down here, it could take a while for it to even show up at the femoral insertion site. For the blood to travel, it could already be on your 30 minutes, right?
Yeah.
Yeah, definitely. Now, sometimes you'll get like those little self-sealing ones where it looks like pepper almost in the helium tubing. Those
I've
are
seen that.
typically okay. And it's just where the helium in the blood turned black. It was like little flecks. Those are typically okay. All right, let me see. Is there anything we need here? Keeping a syringe at the bedside if you get your balloon stuck on inflation. Or if your console goes out, you would have to manually inflate your balloon every 5 minutes until a new console, so it doesn't have clots all in the folds.
Yeah, now don't inflate it and then turn the stopcock off and leave it inflated.
Don't do
That's
that.
bad.
That's
Okay.
bad. Okay, so these are things you would report to the provider: placement issues, things like that, augmentation issues, bleeding, hematoma. We talked about the balloon rupture. You can clamp that tubing if you want to make sure it doesn't make it all the way back to the console.
But we do consider this to be an emergency.
It is an emergency.
This is an emergency.
It is very much an emergency. And again, general rule is 30 minutes to get that balloon out before that blood in the balloon is actually a huge clot. And then you got to have the surgeon come get it. Okay. All right. So weaning, changing your augmentation, timing, so 1 to 2 or 1 to 3. They used to actually decrease your augmentation percent, so how full your balloon is, but it was shown to have a higher risk for clots to be thrown off of a balloon that's not being inflated completely.
Interesting.
So, yeah, and of course, all your hemodynamic markers, your index output, mentation, urine output, stable lactic, all of that good stuff we like. Okay, and then FEM stop typically for removal, strict bed rest, pedal pulses, hematoma, all of those checks. Okay.
Very good.
Sorry, I went over, guys. I tried to kind of rush through the last bit there.
That's okay. I usually make up for it when I do mine. I always end early. That's not true.
So a couple things that I do want to point out, though. The closer your balloon is to your aortic arch, the more augmentation you're going to get. So I think you touched on this briefly. When you don't have a very good augmentation hump, could mean your balloon is way too far.
Has migrated down, got
Right,
pulled out,
right.
anything, or bad placement.
Correct. So you wouldn't have a very good hump there. You can also see that diminish if your patient vasodilates out, and your balloon is not getting as good of a
Seal, so
percentage
to speak,
seal
yeah.
right on there to kick the blood back. So more blood is able to just go past it when it inflates.
Yeah, it probably doesn't actually seal where it
No, it should only be
slams
like
against the walls,
85%.
right?
Yeah, 85% of your lumen should be your balloon. The opposite being true if it is in too deep, you can also get a very sharp, spiky augmentation, and that's a sign that it is in too deep.
And Jeffrey also said that on the balloon where the machine fails, your 60 cc syringe, you can pull 60 cc's or 50 cc's of helium off of the tank and use it.
As
versus
long
using
as
air.
you keep it intact, because once you disconnect, you have to purge all the air out of there in order to fill it with helium,
Yeah,
right?
yeah.
If you're disconnecting it from
Yeah.
the machine, your helium's all gone. It would have to go through a whole repurging cycle on the machine, but how would you do that with a syringe? You would have to completely deflate it, and you can't make that tubing go to nothing. It's pretty rigid. So you can do that, but you're not going to get a complete helium. It's going to still be air.
Okay.
And before
there's
you
a
do that,
port
you
to
should
fill
always
this.
aspirate just to make sure you don't get blood back before you put that 60
Oh, he was
cc.
talking about, I think, more for if the machine failed and you had to temporarily inflate and deflate the balloon every 5 minutes, that you could use helium off of the tank in the back.
Right, but in order to put the syringe on there, you would still have to disconnect the helium tubing, unless you had a stopcock put on there prior to starting therapy, right?
Oh,
and
yeah.
You have a stopcock already in place.
Yeah.
You would still have to disconnect, and all your helium's gone.
Okay. Okay.
So either way.
Thomas, any thoughts? Any questions, concerns?
No, I was looking for all of the paperwork that I have on this, and some things are like, so you have some ideas for troubleshooting the machine when it consistently fails with gas pressure alarms or overpressure, or some ideas about axillary insertions, because a lot of people don't see those.
I don't see them very often.
No,
But
I
they
don't.
are.
I don't either. But I thought that was just a really good, comprehensive lecture. So, if there's any questions from the audience, I'll go through these again. We'll be reporting the winner for all the points on Friday. And Thomas, you can maybe you might even win something. I'm not sure. But we will get this at the end of the lecture. Also, please, if I could ask you all again to go to that mediweb.us and look at the ECMO course. And if you could, just send me an email, if you don't mind, to the contact at perfusioneducation.com, or just email me personally. If you know my email address, probably most of you do. And just let me know if that is a course that you would see as something you'd want to do. And then I can go and submit the applications to the board to get it approved for the Category 1 CEU. If you think the full course is something you would be interested in, let me know that too. That's including the simulation, because I'm seriously considering doing a full course where it's 4 days. You do 2 days of didactic, 2 days of simulation, and then you would have eligibility to apply for the ELSO Adult ECMO Specialist Certification Exam. And I think that the education that you get in that ECMO course is something that Vicki put together is exceptional. I think it's the best course out there. So I just wanted to ask you all to let me know so that I can get some guidance about what direction I should be going. It would be very helpful to me. And with that, I don't have any other questions. I thought that was excellent work.
I do. We are doing a very comprehensive balloon pump course that's going to have the lecture part, it's going to have the demonstration part, and an insertion kit, cath lab part.
Right.
rather.
So you're going to actually have the machine, the
Yes,
simulator.
machine,
You're
the
going to be doing all
simulator,
that stuff, the balloon
timing, the
catheter itself.
errors, different heart rhythm issues and things like Thomas was talking about, but that's going to be all in a demonstration. That's going to be a course on MediWeb.
Is it going to be, so it's going to be virtual?
Yes.
So it
yes.
will be virtual, just much like this is.
Correct, but you're going to have that demonstration part for both the insertion and then actual timing and all
Okay.
of that. So it's going to be about 5 hours total.
Now that particular
very
course.
very in depth.
So that's another thing is, is that another course that we need? Because I don't have this being approved for CEU through the
Not
perfusion
through the
board.
yeah.
Because, I assume the perfusionists know how to run balloons, so we're learning with some of the younger people that I'm seeing coming out of school that they don't. And so this
Yeah.
may be very useful. If y'all could let me know about that as well, I'd appreciate it.
That one's going to come with a certificate as well, so that one probably would be handy
Okay, very good.
to have approved.
Thank you. If there's not any further questions, Thomas, you want to wrap us up?
Sure. Don't forget to like and subscribe.
Thank you. And Kay Garcia, thank you. Great job sent to you. So,
Thank you.
and with an applause, I appreciate it. All right. We'll see you all tomorrow. We get, hopefully Thomas is feeling better, and he's, we're going to have first treating hemodynamic disturbances, our own Vicki Carlyle here, and then the pressure is on weaning from CPB, and that will be Thomas DeSalvio. And we will hopefully all be here, or Thomas may be virtual if he's still sick and infectious. We don't need to be, we all don't need contagious. We don't need to all get sick again. And we'll have a lot of fun with it, however, because I think that between him and I, we bounce off each other pretty well. So it should be a lot of fun.
Yeah.
Okay. Let everybody
Thank
know
you.
we'll see you tomorrow.
Guys, thanks for this great talk.
Bye. See you.